I've got a little bit of cold. So that's what you're hearing. And just to give you all a little bit of a warning, I've had post-viral fatigue for the past 4 years. And so when I do presentations, I do look at my slides quite often, and that's just to help me pace. In New Zealand, it's 10:30 in the morning, so I just have to pace myself well for the rest of the day. But yeah, so I'm here today to talk about the intersection of health and digital ACT interventions. And to give you some background about me, the accent is from upstate New York in a city called Binghamton, and that is Iroquois Nation land. And about 10 years ago, I came over to New Zealand to pursue a PhD. So now I live, work, and play in Dunedin, New Zealand, and that is Ngāi Tahu land. That's the iwi, or the indigenous tribe down here. And so they are the Kaitiaki, so the guardians of this land. And a little bit about my ACT background. 10 years ago, I did a 2-day, maybe even a 3-day course with Steve Hayes in New York City. And since then, I've learned about the DNAV model with Joseph Trocchi and Louise Hayes, and I've helped facilitate a leaning into ACT intermediate to advanced level workshop with ACT therapists down here in New Zealand. So ACT has been an important part of my life and research for the past several years. And so what I thought I would do is go into a little bit of detail about research that I've done. And interestingly, I started presenting bits of this research at the World Conference in Sydney in 2013. So it's amazing how long it takes to get through all the bits and pieces of research. But I found an email that I had sent out to other researchers for the Acting with Technology panel at that WorldCon. So yeah, time flies when you're having fun. So yeah, I'll tell you about this online program that I developed for my PhD, and the program was called Mind, Body, Food in Maori. That's Hinenaro Tinana Kai, and this intervention was developed to help mid-age women reduce the likelihood of gaining weight in mid-age using intuitive eating skills and acceptance and commitment therapy skills. And if you're not sure what intuitive eating is, it's an approach to eating behavior where you listen to your body for what to eat, when to eat, and how much to eat. This adaptive style has been associated with like higher self-esteem, better mental health outcomes, lower body mass index, reduce risk for eating disorders. So there's lots of benefits and more to eating intuitively. And when I first came to New Zealand, I analyzed a large data set from mid-age women, ages 40 to 50, and there were about 1,600 women in the sample. And I found that psychological flexibility was associated with weight stability. So that means that when somebody was psychologically flexible, they weren't gaining weight over time and they weren't losing weight over time. So that was a short period of time. I was looking at just 3 years. So with this evidence that eating intuitively and psychological flexibility were associated with weight maintenance, we had that evidence to go ahead and develop a web-based program to promote those sorts of skills. And this is the homepage that somebody would land on when they would go to the online program. And what I'll do is I'll take you through what the modules were and then take you through the individual parts and let you know how a small pilot study turned out. So there were 12 modules to this online program. It was self-guided. Each module took about 15 to 20 minutes to complete. And the titles and the content was informed by the book Intuitive Eating by US dietitians Evelyn Triboli and Elise Rush. And then I wanted to point out that this research has made its way into the 4th edition. And ACT Made Simple was a tool that we used for developing the content. When I say we, there was myself and a master's level dietetic student helping me develop the content and test it in focus groups. And then we used other intuitive eating, mindful eating, and ACT publications. I see a question has come through wondering whether the weight stability through psychological flexibility would help people recovering from eating disorders. And interestingly, Rhonda Merwin over in the US at Duke is using ACT for helping treat eating disorders. And then I see someone has popped in responding to that question. Yeah, so I'm going to click through the different module titles. So module 1 was about letting go of diet rules and letting go of the idea of there being forbidden foods. And the reason why that was really important to start out with is just to set the tone of the rest of the program. So the idea, like I mentioned, was to prevent weight gain, and most people sign up to an online program like this with the hopes of losing weight. And so that first module talked a bit about this dieting cycle where somebody has this urge to start dieting. They're reducing what they eat and how much they eat. They get really restrictive. And then over time, that deprivation for most people leads to some sort of binge behavior. And then after a binge, somebody might feel like they're a failure and that they don't have willpower. And then over time, they start a new diet and continue this cycle of restricting and then caving into the forbidden foods and then going back into dieting again. Then we had a module specifically on recognizing physical hunger, because I don't know for a lot of you, but my experience with women has been somebody who's been dieting for about 20 years doesn't necessarily notice their hunger until it's quite extreme, or they don't trust those hunger signals to guide when to eat or how much to eat. So we spent some time getting women to think, where in your body are you noticing these urges to eat? Is it in your head? Or is it in your mouth? Is it in your stomach? And getting used to listening to those signals. Then we have recognizing fullness. Another way of thinking about fullness is actually thinking about satisfaction with the amount of food that's eaten. And so helping people who generally stopped eating when all the food is gone and feeling uncomfortably full move towards finishing a meal when the hunger cues are gone and feeling satisfied with the amount of food that was eating. We did spend some time teaching about mindful eating, so paying attention to the food. What does it look like? What does it smell like? What is the texture feeling like when it's in your mouth? The idea behind that is, over time with practicing mindful eating, getting better at choosing foods that are satisfying and having the experience of eating feel more satisfying. And the idea behind that is, when a meal or a snack or a drink is satisfying, then you need a smaller amount of food to feel satisfied. So that's where the idea of weight maintenance would come from. Then we had a module on coping with cravings, and the way that cravings were defined in this program was an urge to eat when not physically hungry. So what do you do when experiencing that? And as you would imagine, there was a lot of acceptance around that, and urge surfing. So seeing if the feeling of hunger grows and then gets smaller over time within 10 or 15 minutes. Then we talked about emotional eating. So instead of eating to no longer feel bored or lonely or sad, is there something that's values aligned that you can do instead? And if in that moment eating to cope with feelings feels right, then mindfully eating and allowing that experience. And then we have cultivating body appreciation, which was a really interesting module to test in focus groups, because women in particular are often told that this thin ideal is what we should be striving for. And this cultivating body appreciation was a module that changed thinking from our body can only be thin or fat to our body can be robust and agile and strong, or our body is more than a bunch of organs that we're trying to control and things like that. It's for women, our body has been an opportunity to bear children. We have arms that allow us to hug our children or take care of our elders, things like that. So spending time on thinking about all the different ways that our body helps us do the things that are important to us. Then dealing with pressures to diet. This even comes from pressures from a doctor to diet, because we're still at a time where people can walk into a GP's office and show up for knee pain, for example, and then the first thing the doctor looks to do is prescribe weight loss rather than pain management or other approaches. So that dealing with pressures to diet from GPs, but also friends and family, so that if somebody's finding intuitive eating helpful, they're more likely to stay with it. Then taming the inner critic would be around how do you cope with being in a society where chocolate cake is thought to be quite a negative thing, and allowing that space to think that actually chocolate cake can be enjoyable, whether it's for a celebration or not a celebration, and enjoying that experience. We also had a mindful physical activity module. So thinking about moving our body because it feels good, not because we're trying to control weight or shape. Eating fruits and vegetables and lower fat foods was a way of introducing gentle nutrition towards the end of the program. And then staying on track. A lot of people who have a dieting history would feel like, oh, I've fallen off the wagon. I'm eating these foods that I said I wouldn't, or eating amounts that I said I wouldn't anymore. And trying to reframe those as just learning opportunities. For me, if I have one chip, it leads to eating a whole bag of chips sometimes, and not getting down about feeling like a failure, but actually noticing that afterwards I don't feel really good. I have these yucky, gross feelings. And so in the future, thinking back to that and how is that past experience going to inform my future behavior. So those were the module titles. And I developed content for each of those modules. Paper versions of that content were presented in focus groups, and I did have focus groups specific for Maori or Indigenous New Zealander women to get their feedback, to make sure that the content would be appealing and in line with Maori values. And also the reason for that was trying to make sure that I wasn't creating something that just Pakeha or Caucasian white women would be interested in, so that we're not creating a program that would increase health disparities. So that was important. And I also ran focus groups and did interviews with Pacific women. So in New Zealand, we have a large population of people from Tonga and Samoa and Fiji and Cook Islands. So making sure that the content would be appealing and useful for women from those countries as well. After all of that content was pre-tested in paper versions, then a web developer translated all that content to this online program. And so now you can see what the layout looked like. And once somebody logged in, they would watch this video of a woman who was trying to move away from dieting and become more of an intuitive eater. So she talks about the difficulties that she's expecting to experience with whatever the topic of the module is. And then there were two friends who were intuitive eaters guiding her through what their experience had been like trying to take on board whatever the topic is. So for emotional eating, tools that they use to cope with urges to eat when not physically hungry, for example. So after they watched a video, there's this audio activity, and a lot of you might be familiar with Leaves on the Stream. So we recorded a Leaves on the Stream audio activity, but also some body scans and where do you notice different sensations in your body and how would you label them? Would you label them as hunger or thirst or fullness, for example? And the idea behind that was to cultivate mindfulness. And then after the audio activity, there was time to reflect on what they had watched and what they had listened to, and imagining how life would be different if those different skills were taken on board. And then at the end of each module, there was this opportunity to set reminders to self-monitor behavior around eating when noticing subtle hunger cues, finishing eating when those cues are gone and starting to notice fullness signals, and also rating how mindfully somebody was eating. And all three of those were rated on a scale from 0 to 10, where 0 was not at all and 10 was completely. So with the hunger and fullness scale, the 0 end would be absolutely now I'm having a mind blank, being really ravenous with hunger. So that was actually what 0 was. And then at the other end was fullness, with 10 being actually overly sick from eating too much. So that's how it went. And then after the module is completed, women can go back in after eating like a snack or a meal and then monitor their ratings, with the idea of trying to maintain within a certain rating range each day. So they might notice they're eating when their hunger on a scale from 0 to 10 is maybe at a 7 or an 8. So then over time, logging comments about what foods were eaten when you noticed that rating, and how much did you eat and how did you feel afterwards. So I did do a pilot study with 40 women down here in Dunedin, New Zealand, and they had 14 weeks to complete these 12 modules. And at the start, before they started the intervention, they completed the intuitive eating scale second version. So that's 23 items. And those items are measuring if somebody's eating for physical rather than emotional reasons, giving themselves unconditional permission to eat what they want and when they want and how much they want, reliance on hunger and satiety cues, and body food choice congruence. So choosing foods because they help someone's body feel well. And then they also completed the acceptance and action questionnaire to measure psychological inflexibility, and those were pre and post measures. And at the end of 14 weeks, the results were greater reductions in psychological inflexibility, and that was associated with increases or greater increases in total intuitive eating scores. And what else do I have here? From pre to post intervention, there were statistically significant changes in general mental health that was measured with the short form 12-item health survey, and reductions in binge eating. So if you're not familiar with how that's measured, we just use 2 items. How often in the past month have you eaten an amount of food that others would consider too large? And did you feel out of control at that time? And what we also noticed is from post-intervention to 3-month follow-up, that the intuitive eating behaviors were maintained. So if somebody had low intuitive eating scores before the intervention, those scores went up, and then that behavior was maintained at the 3-month follow-up, and improvements in mental health were maintained. And then I noticed a marginal but non-significant tendency for further improvement in psychological flexibility. I had also measured women's weight at 3 time points, so pre, post, and 3-month follow-up, and women maintained their weight over that period of time, which is what we were expecting to see. So a lot of time had gone into developing content for 12 modules and then testing them. We had evidence that this sort of intervention did prevent women from gaining weight in the short term. That was really difficult to get funding to run a randomized controlled trial, and it was expensive to maintain this online intervention because it needs to be hosted somewhere, and then there needs to be money to keep updating it as our phone browsers are updated, and the web browsers that we use on computers, and there's just a lot of costly issues with keeping this program online. So what has happened since this time? So you see the paper was published in 2016. So what's happened since is we've translated this program into an in-person group-based program, and the name has changed to the Wellbeing Program. So we took most of the modules from the Mind Body Food program and kept them, but also had a look at what the diabetes prevention program in the US had been teaching to reduce the risk for diabetes and cardiovascular disease. So again, we have a 12 module program, but instead of the focus being on weight gain prevention, it's now focused on diabetes and cardiovascular disease prevention. And instead of set it and forget it, having these modules that people choose to go and complete, we have nutrition students who are delivering these group activities. So there's no longer a tech component to it per se. The students try to set up Microsoft Teams so that group participants, there would be maybe about 10 to 12 people per group. So trying to organize a space on Microsoft Teams for them to get in touch with each other for social support or for organizing group walks. We found that with our demographic group, which would be adults 18 plus were eligible, but I think the average age of participants is in their 50s at the moment. Most folks are not familiar with Microsoft Teams. They're more familiar with Facebook. And so then there were issues around figuring out how do you make a private Facebook page when you're planning on running a program long-term, but with new people in the group. So we haven't figured out how to there's no data yet on this program's effectiveness being run in a group setting. We're just collecting the data at the moment. So it took a long time to go from a web-based program to a group-based program. We had that pandemic in the middle, which isn't completely over, but yeah, affected how this was translated. And I thought I'd mention some other work that might be of interest to some of you. It's completely different than weight gain prevention or diabetes prevention and cardiovascular disease prevention. So developing Mind Body Food and the Wellbeing Program gave me experience with teaching psychological flexibility and act-based skills to people And when I finished my PhD, all that work that I just described was part of my PhD, there was a pediatric endocrinologist in this city who needed somebody to run some diabetes studies for him. And I found myself doing type 1 diabetes research. And originally, I was doing diabetes technology research. So what happens when you give young people with unhealthy type 1 diabetes technology, and do they get healthier with it? And we found out that you can take away the painful ways of monitoring glucose levels, for example, but you don't see those clinical numbers changing. And we thought that was interesting. So I suggested, let's see what happens if we test out values-guided type 1 diabetes management in young people with type 1 diabetes. And the endocrinologist thought, yep, let's give this a try. So what I've done most recently is I've been meeting with young people with type 1 diabetes between the ages of 13 and
I think we froze Sarah. No. Cliffhanger. Yep.
Looks like she just left, so hopefully she can
Yeah.
rejoin.
I'm sure she'll try.
Who else here works on digital interventions in their work, either research or otherwise? Is everybody in a research role or in other capacities?
All
So
the
I-
capacities.
sorry about that. My computer decided it wanted to do an update, but then I realized I was talking for so long. When I only thought I was going to talk for 20 minutes. So I've got about 5 minutes left of slides, if that's okay. Yep. Yeah, sorry. Let's see if we'll move that out of the way. All right. So most of you, if not all of you, will be familiar with the ACT matrix. I modified it a little bit to be specific to diabetes self-management. And I've been meeting with young people online just like this, but sharing my screen and sharing a Word document with the matrix here, and just going around and asking questions about what's a change that you want to make to how you take care of your diabetes. And asking, all right, what's getting in the way of taking care of your diabetes in that way, thoughts and feelings, and what could I see you doing? And then going into action planning. And this has been the first time for most, if not all, of the participants where they've been asked how they want to take care of their diabetes, and how taking care of their diabetes in a new way would help them engage in life and have the life that is personally meaningful. And I do ask them what their values are, and sometimes they don't know. So some of you will be familiar with the virtual values card sort. And this has been shared in different listservs. It's a PowerPoint presentation, and these rectangles are values, and then you sort them into a pile of, one pile would be the very important values. The middle pile is the ones that are important, but not the most. And then a pile for the least important. And you can see that some of the values have been translated. So up at the top, we have Andre McLaughlin mentioned here. So in New Zealand, they had Maori clinical psychologists come up with Maori or indigenous specific values, and then those were translated to English, and then I put them into this card sort. And if somebody isn't sure what their values are, then we take 5 or 10 minutes and get them to start moving values into piles, and then I save it and email it to them afterwards. Yep, I can share the deck at the end. So this is what I've been doing, pilot testing it to see, do young people even bother showing up to Zoom meetings like this? And do they like talking about their values and new ways of taking care of their diabetes? And then I think for some of you, you might find this last project interesting. So once I came up with a protocol for how do you meet with somebody online and talk through values and how their values will inform type 1 diabetes management, I decided that would be really interesting to figure out what is the best combination of intervention components to help this particular group of patients, because type 1 diabetes isn't curable. And when somebody has type 1 diabetes, at risk for cardiovascular disease and kidney problems, eye problems. So it's really important to make sure glucose levels are in a healthy range for as long as possible. And I've been running this optimizing short-term glycemic control research. And what that means is instead of a traditional randomized control trial where you have your intervention group and your control group, and you have your intervention phase and you compare outcomes before and after, this approach is where you have a certain number of intervention components. People are randomized yes or no to those intervention components. And then you compare everyone who got a component to everyone who didn't get a component. And of all the individuals in a trial, you could have a small group that gets no intervention and a small group that gets all the interventions that you're testing out, and everyone in the middle gets some sort of combination. So I've been testing what happens when you give young people with type 1 diabetes the latest and greatest continuous glucose monitoring technology. So instead of pricking their fingers 6 to 10 times a day, it's a sensor worn in the arm is sending glucose levels to their phone. So that's one intervention, which is what we've been looking at in the past. We've been looking at sleep support because there's evidence that getting the recommended amount of sleep is associated with healthier glucose levels. Then this values guided diabetes management, and lastly snacking, because I'm in the nutrition department at the University of Otago. I needed to have an intervention component, and right now I'm analyzing the data to figure out which of these combinations improves glycemic control best. And that's it for what I've been doing. I see something's coming through the chat. Is this approach related to process-based therapy? So Matt, good question. I am so new to process-based therapy, and so I can't tell you that for sure, but I think so. So that's me. And sorry that I talked for so long. 36 minutes is a long time to hear about intuitive eating and type 1 diabetes.
Oh, it's no worries at all. So we can go ahead and open it up to discussion now. Feel free to ask Sarah any questions. This is a brown bag, so this is meant to inspire more robust conversation. So feel free to direct questions to Sarah or just amongst each other. And thank you, Sarah. That was actually a really amazing talk.
Yeah. Is there anyone here who's either in the process of developing something online for a health condition?
Many somethings. I did have a question. Well, thank you indeed. And it was awesome and inspiring. I did wonder about why this, and maybe I might kind of intuit the answer, but why this moved from like a somewhat virtual project to a non-virtual one.
Yeah, and
And
it
I
had to do with funding.
Yeah, I really felt that part when you mentioned that. For my PhD, I did it was an online acceptance and commitment training. It was pretty much based on protocols about acceptance and commitment therapy used in the workplace to improve well-being. So I took those protocols and I created an online like a course on Moodle eventually, because I didn't have any other platform to use. So basically, upon graduation, it will just be a file in my computer, because it's impossible, even if it is just for a small project, to keep it up and running.
Yeah, Moodle's a really great option, or
However,
Blackboard.
each year it requires a fee to sustain it. So yeah, yeah. So I can imagine in your case that it was a large program, the cost would be much higher.
Mm.
Yeah.
Yeah, with New Zealand being small, but people are so geographically widespread, you might be 5 hours away from some sort of health center. That the online intervention was meant to overcome those barriers to getting mental health and health specific support. But yeah, finding a way to pay for a program to be online long term, just not possible at the moment.
Did you explore any like payment scheme for people, for instead of being so you could develop revenue to keep the program running?
That's a good question. Actually, at one point we looked at doing crowdfunding, because women in the focus groups and the study participants really valued the experience. But yeah, that just never got off the ground. And also with, paying $5 or $10, finding somebody in technology at our university who could help us set up that was easy enough, but to maintain it, like, you don't know where a PhD student is going to go. And so having people around to keep the online stuff going was just really tricky. Yeah.
Ruben, did you want to say something? And I just cut you off earlier. I think I saw your little hand.
Yeah,
Sorry.
no worries. I enjoy listening to what y'all are sharing. That question, is anybody creating digital tools for different conditions? I worked for a digital health platform in the content arm, Health Solutions. I did a lot of content, programmatic self-guided stuff for different health conditions, and I had just started exploring applying ACT with the product features before I was laid off. So I have like a whole bunch of frameworks, like and different web and mobile app tools, like, I don't know, quizzes, tables, drop down stuff that gets pretty flexible in how it delivers the ACT interventions. I've got some basic training in ACT, but I mostly did it for stress and anxiety. I had written some programs on mindful eating, the relationship between the mind and the gut. So seeing, and some on diabetes too. So seeing the link explicitly between ACT and diabetes and mindful eating, all of that's really great.
So what I'm doing at the moment is just seeing if I could flick through the virtual values card sort. And that'll come through the chat if anyone wants to see that. The version that I'm sending through is all English, because I don't have permission to send through the Maori versions, but there's at least one person who's in New Zealand who's planning on watching today's talk. And so if that person is interested in Maori specific values cards, they can email me at sarah.stiles@otago.ac.nz, and I can give them more information. Because you have to, for the Maori specific cards, you have to go through training to understand the history behind the cards, where you can't just take Maori values and then share them widely without having the history. So for the, I see a question for the first project, it was intended for weight management, but did you see a significant weight loss by chance? No, interestingly, for some of those study participants between baseline and when I saw them 14 weeks later, there were actually a few women, one in particular who probably gained, she said 12 kgs, and I can't remember exactly, but for some women, instead of losing a lot of weight, they gained a bit of weight. And when I had a chat with her, it was her partner had been doing all the cooking for her, and the way that our content was worded, it was you as the individual now take control over everything that goes into your mouth. And she wasn't somebody who was cooking at before the intervention, and so for her, she then moved on to packaged foods that were easy to consume, and she just found that eating packaged meals caused her to gain weight. And then we had a chat, and I said, it's okay if your husband cooks for you. And so I don't remember the exact outcome for her at the 3-month follow-up, but I don't recall any conversations where she said that she had gained more weight. But that's one of the drawbacks of an online intervention, isn't it? We had done so much work in focus groups, and yeah, to have an outcome like that was unexpected.
Hello, Sarah. Thank you very much for your presentation. I were
Jeffrey, I don't mean to cut you off, but you are cutting out, so we can't necessarily hear you. It sounds like there's a problem with the connection. It might be better to type it in the chat.
And you froze.
Well, in the meantime, I had another question, Sarah. I was curious about those focus groups you mentioned about making the intervention more culturally adaptive or acceptable to a diverse group. I'm really curious about how those conversations went. What feedback did you get? If you made any changes to the site? I always make an attempt to do that with the interventions I work with, but I go to grad school in Utah, so it's a predominantly white population, so I never end up getting a lot of juicy feedback on that.
Yeah, it was interesting with New Zealand. We have the Treaty of Waitangi, which was signed between the British Crown and Maori chiefs. And that was well over 100 years ago. And it kind of set these rules or obligations where the government and then flow on to researchers. We have this obligation to uphold partnership and protection of Maori culture. And so that is one of the reasons why you see me talking about Maori values and focus groups. Whereas when I was in New York, we never talked about Native American anything. So the process here is finding Maori academics who have connections with the community. And you don't just put a post on Facebook saying Maori women come do a focus group with me. It's you have to know someone who knows someone, because participants need to know that I'm a safe person to talk to, that I'm not just stealing women's thoughts and ideas and history from my own benefit, which was a PhD, that they have to feel like I'm genuinely going to give back to the community. And then through those focus groups, women appreciated intuitive eating because it wasn't these outside Western rules about how to eat, that they have a very holistic approach to health and well-being, and that listening to our body aligned well with that, but also the acceptance and commitment therapy side aligned well with that too. So one of the health models that we use in New Zealand is Tawhare Tapa Wha, and that means for somebody to have good health, they need to have good spiritual health, good mental health, good physical health, good social health, and have connection with the land. And so the acceptance and commitment therapy side touched on some of those other core values, which is different than how Western approaches look at health quite often.
I just want to say I'm so excited to hear about your work, Sara, and appreciate you being here. I work for a weight loss weight management company that uses continuous glucose monitors. And so I'm actually tasked with like developing behavioral programs using continuous glucose monitors, and everything you're saying is like very up the alley of the types of things we're doing. And it's interesting because we also have a private Facebook support group for, you know, the members that use our product. And it's interesting because a lot of the comments that people provide when they're just chatting amongst each other are very much in line with like rigidity and inflexibility, and kind of using those glucose values almost like to their own health detriment. Like, oh, I had a spike, like I'm doing everything right, why am I even using this? And so it's interesting because I recently did like a little deck for my team, and one was like a picture, I used the Hexaflex, one was like psychological flexibility and sort of what we expect to see with women who are managing their weight, or we recently are accepting type 2 diabetes on the platform as well as of about last month. And so basically when women are psychologically flexible, what can we expect to see and sort of hear in their discussions, versus when they're inflexible, what are the types of things we would expect to see? And the whole team and the engineers were like, wow, like you must be stalking the Facebook group. This is exactly what everybody says. And it just underscores for me like the research you're doing, it's so needed. And yet I think there's such a big disconnect between some of the health products that have a ton of money and resources and actually what gets put in them, and then all these wonderful programs that you're talking about developing and not having the funds to kind of keep going with them just like rips out my soul, quite honestly, because it's amazing work that you're doing.
Oh, thanks. Related to that, Michelle Josby was doing her PhD at Otago and went on to do some research with continuous glucose monitors and hunger training, which almost aligns a little bit with what you're talking about. And what she found with hunger training is somebody might have this urge to eat or feel physically hungry, and then they'd either have to prick their finger or scan a sensor to see what their glucose value was. And if it wasn't low enough, that they didn't get to eat, and they just had to wait to eat. And for those of us in the intuitive eating field, that just felt like an uncomfortable thing to say you can't eat yet.
Yeah, some of our executive team really loves the idea of hunger training, and I'm trying to rebrand it as interoception, and basically helping people develop a little bit more of like a flexible relationship with like, okay, yes, check your glucose, and how do you physically feel? Like, what are the subjective reasons you might want to be eating? Because if you're just relying on an objective number, like that's not, I mean, that's rigidity. You're just slicing it in a different way.
Super interesting.
Question here, but I don't know if you can hear me. Connection is very
now I can hear you.
Yeah, I started before, it didn't work. So the question is, when you are trying all those interventions in the last slide that you were presenting, what are you measuring in the people so that you can know what kind of features or what kind of characteristics of people can predict success of some intervention?
That's a great question. So I was looking at short-term glucose levels as the outcome. And what that means is before the intervention phase, everyone wore a blinded glucose sensor, and it told us what proportion of time over 2 weeks were their glucose levels in the clinically recommended ideal range. And then everyone wore glucose sensors that blinded their glucose data 2 weeks later and 4 weeks later. And I was looking at the proportion of time. Did it move towards the, sorry, now the cat's here. Was it moving towards the clinically recommended range? And the idea behind that is the short-term glucose levels where you get results sooner than waiting for HbA1c or glycated hemoglobin to change. You'd have to wait 3 months for that. But everyone in the type 1 diabetes research has an HbA1c that's well above recommended. Yeah, but we're looking at short-term as well.
But you didn't measure psychological related like to say such things as, oh, for people that score low on psychological flexibility, for example, that type of intervention seems to be more effective.
Right. So with the psychological flexibility, they have been completing the compact, and there is a youth version for that to measure psychological flexibility. We knew that we would be underpowered to look at it as a mediator, but what I was doing, I was collecting psychological flexibility just to figure out if collecting that would be feasible, because these are teenagers and young adults with a chronic condition that they're struggling with. And each time you give them one more thing to do, you're even more likely to not get, like, something's got to give. And yeah, I had to be really careful about the amount of information I asked and how burdensome it was. Yeah, so if anyone wants to really practice their own psychological flexibility, I highly recommend working with adolescents and young adults with a chronic condition during a pandemic, because that's what the past few years have been. I see Corey's put through that the next time the group is meeting is in August, which is awesome. And I didn't mention that Jason Lillis at Brown was the acceptance and commitment therapy expert. And so he's an author, one of the authors of The Diet Trap. And so we did have all the content peer reviewed to make sure that we aligned with best practice. So we had an intuitive eating expert, Tracy Tilka, also look at the content as well, which you don't necessarily see on commercial apps, going through all the processes of the focus groups and the expert reviewers.
Which is why I feel sad that your program isn't publicly available.
I know. I went to, we have a Center for Innovation, and they said they absolutely do not help with getting apps funded, because they don't help with things created for public good. There's got to be a way of making money. And when we said, okay, what if we do charge $3 or $5 or $10, which isn't what we wanted to do, because we didn't want to increase health disparities between people who could afford to pay the $5 and people who couldn't. But yeah, they just said apps are not profitable. So couldn't get help there either. But so far, the group intervention is in person is going really well. And I suspect there will come a day where we end up doing group sessions over Zoom. And so that way, I'm at the bottom of the South Island of New Zealand, but that way in real time, I could work, or students could work with people at the top of the North Island. And that's one way of overcoming some of the barriers to support that people are after.
Yeah, I was thinking about that, like the low tech solution to scale without the disparity and inequity could be like a virtual format, and using some of the kind of virtual low tech tools, like, you know, the values card sorting. I think those are ways in which we can bridge those divides without getting too caught up in, and I guess to think flexibly and problem solve in a flexible way around, like, it doesn't have to be a sort of high end, you know, mobile app or something like that. There's such a spectrum, and we can remain flexible, hopefully. I'm still a little bummed about that as well, like Corey said, and I am sort of kind of on the side. You may or may not have the answer, and just kind of existentially wondering, like, why would in-person care be more feasible than scaling tech? And so that feels paradoxically incongruent. So there may be some major stuff that I'm missing there. But anyway, so that was like a passing thought I had, that it doesn't resonate with what I hold true in my brain. So, but anyway, just amazing work.
Yeah, with the in-person stuff, that does align better with Mallory values, where face-to-face is preferred. And that's how you build those connections, those social connections with people, especially strangers, taking time to build those relationships. Because the Mallory view of health is that it's taonga, it's special, and you protect stuff about your health. And to go into a room and then start talking about why you emotionally eat isn't a safe thing to do. Most people are not comfortable with it, especially. But from an Indigenous perspective, there's another layer of protection that happens. So being in a group space, you get that sense of, are these safe people to share about my health with? So I don't have any evidence of that, but I think there's some of that at play a little bit, just making sure that everyone is there and protecting people's knowledge and experiences in a really safe, culturally safe way.
Well, thank you so much, Sarah. We're at the hour, and I posted all the announcements in the chat, but just to reiterate, if everyone could fill out the survey, it's much appreciated. And I think everyone in this room is qualified. I mean, like, overly qualified to be a brown bag speaker for one of our future events. Geoffrey has given one before. All of our brown bag events are basically community driven, where people from our group just come up and talk like Sarah did today. So if anyone's interested in presenting in the future, just shoot me or Erica an email, and we're looking for a speaker for our next brown bag, which is going to happen probably in September or October. In the fall. So just reach out. All right, see you, everybody. Bye.
All right.
Thanks so much.
See you. Thanks for coming.
Thank you. Bye-bye.